Welcome to EuroPCR 2025. My name is Prendergast, and our topic for discussion today is the role of cerebral protection at the time of TAVI procedures. And there's no one better qualified to join me and to discuss this topic than Rajesh Kharbanda, my long-standing friend and colleague from the John Radcliffe Hospital in Oxford. Raj, stroke has been a devastating complication of TAVI that is feared by patients and by their cardiologists. And for many years we've been using cerebral protection a little bit randomly, some would say routinely, to protect patients in this specific procedural setting. And in the last year we've had two very important randomised control trials that have addressed this question in a more robust, systematic way. Can you summarise those two trials first of all?
Yeah, so the first trial was the PROTECT-TAVI trial. That was a trial of 3,000 patients conducted across the 51 sites in the United States, in Europe and in Australia. And that was a one-to-one randomisation with embolic protection or not. And that trial published, and it was neutral. The primary endpoint was neutral. The stroke rates were just over 2% in both groups. It had been powered for a bigger event rate, so there's a bit of question about the powering of the trial. There was this signal toward a reduction in disabling stroke. So that was a couple of years ago. We'd already started the British Heart Foundation PROTECT-TAVI trial at that time. And that was a larger trial aiming to recruit over 7,500 patients in the UK across all of the participating TAVI sites. And we got 31 of the sites. So, and that presented at ACC and was published in the New England Journal. And that trial was also neutral for the primary endpoint of stroke, and no difference in disabling stroke.
And importantly, that latter trial, the British trial we'll call it, was very representative of everyday practice in that a very high proportion of all TAVI patients in the UK were randomised, correct?
Yes, that's a really important point when we look at randomised trial data. How representative is it? Exactly so, and we recruited nearly 1/3 of all TAVI cases happening during that time, which for a clinical randomised trial is an impressive figure. And if you look back at PROTECT-TAVI, for example, across 51 sites over 2 years to get 3,000 patients, you know, the funnel is big that allowed. So there was quite a lot of selection going on in terms of which patients were enrolled into that trial.
Absolutely. Now you've told us that both trials were negative in the sense that they showed no benefit of the intervention arm, the deployment of a cerebral protection device. But here in Paris, you've presented a meta-analysis of the two individual studies. Somebody might say, why bother if both trials are negative? What does meta-analysis tell us over and above the individual trials?
Yeah, so it's to really combine the data at individual patient level. So you can obviously just average the numbers, but the advantage of an individual patient meta-level analysis is that you can align a data set, you can register the endpoints more accurately and align the endpoints. You can align the patient characteristics in a much more granular way than just averaging the data.
Okay.
So that's the advantage. And the idea, therefore, is that you can draw out signals that you can't from just looking at the average of the trials.
Okay. So I've made an assumption, but tell us and reiterate the findings of the meta-analysis.
Yes, so the meta-analysis showed that that embolic protection routinely used does not reduce the incidence of stroke or disabling stroke as a routine strategy.
Okay. So that's a very important message for the community. As I said at our introduction, a year or so ago there were many centres using it systematically. There were other centres trying to pick out the patients who they felt clinically were at most risk. But this trial, for the moment, puts an end to that discussion.
Yeah, I think routine strategy, we can firmly say there's no evidence to support that. So, yeah, I think that puts that clearly answers that question.
So where do we go from here, Raj? I mean, the field is still open. There are other devices. There are other strategies. There may be some sub-analyses that need to be completed. Tell us the next chapter of this research.
Yeah, I think that's a really important point to bring out, that this isn't saying we shouldn't use the technology at all. We know, as you've said, stroke is a devastating complication, and we all want to do interventions and do things to reduce that. The approach is really, I think now, to say, well, who is at higher risk of stroke? And we don't have a powerful stroke risk prediction model. And by looking at the information we've got from these trials, we can develop that, we can validate that, and then we can ask the question, do those patients at higher risk benefit? Remember, stroke incidence is quite low, so we don't want to treat many patients without seeing a benefit.
Absolutely. So the story isn't over yet. A very important meta-analysis presented here in Paris, but watch this space for future developments in the year and the year or two to come. Thank you for joining me, Raj.
Thank you, Bernard.